during practical examination, whenever you are handed over a bone, say a long bone, all right, like this one, what will you do? They may ask the question, determine its side and hold it in anatomical position. Otherwise, you have to determine its side and hold it in anatomical position, right? So, to determine its side, you should know a dictum. What is that? Above and below is, write down, above and below is known by, above and below is known by, anterior and posterior is known by, right? If is known by, known by, yes, known by, anterior and posterior is known by, and if it is a lateral bone, then lateral and medial is known by, and if it is a central bone, axial bone, then the sides are known by. Above and below is known by, anterior and posterior is known by. If it is a lateral bone, lateral and medial is known by. If it is a central bone, its sides are known by. Got my point? This dictum you should follow. See, above and below is known by, anterior and posterior is known by. If it is a lateral bone, known by, K-N-O-W-N, my God. What's the problem? Okay. Anterior and posterior is known by, it is a lateral bone. If it is a lateral bone, then lateral and that is one-sided bone, then lateral and medial is known by, right? And if it is an axial bone, then its two sides are known by. There will be no lateral and medial in case of a central bone. It will have two sides, not the lateral or medial. Got my point? So, suppose this is the bone. Alright. So, first you have to determine its side. So, above is known by the globular head and below by the rough but smooth, irregular but smooth articular surface. Got my point? Anterior and posterior is known by. In the anterior part, there are two fossae, the radial and coronoid fossa, and behind there is the olecranon fossa. Olecranon fossa, this one is the, there attaches the tip of the olecranon process of the ulna, right? So anteriorly, this is a ceramic bone. This doesn't show all the features. This is a ceramic bone, not an original bone, right? So these fossae are absent here, but the olecranon fossa at the behind, at the back is present. So above is the globular head, below is the smooth but irregular articular surface, right? Anteriorly there are two fossae, radial and coronoid fossa, right? And in the back there is a deep olecranon fossa. So above and below is done, anterior and posterior is done, then lateral and medial. Remember, the greater trochanter is lateral. The greater trochanter is lateral and tells the side. It's lateral to in which direction? If you put it here, then it will be medial. If you rotate it wrongly, then the olecranon fossa will come forward. So this is not its position. So you take this to this side. This is the head. This is the lower end. Right? Olecranon fossa is back. Got it. And the greater tuberosity is lateral. So it is right-sided humerus. Got my point? It is right-sided humerus. This will be your answer. But don't tell the dictum. Don't tell the dictum in front of the teacher. You utter it, murmur it within you and do things, and the teacher will observe what you are doing with this bone. Got my point? What happens in the examination? People take this to this hand, rotate this, comes to, holds it, holds by this hand, then again changes this, then changes like this, then rotates this continuous cycle goes on. Got my point? So remember this dictum. Above and below is known by sorry. Anterior and posterior is known by, lateral and medial is known by if it is a lateral or unilateral bone, right? And for axial bone, its two sides are known by. If it is a vertebra, anteriorly there will be the vertebral body, posteriorly will be the neural arch, and in between there will be a vertebral foramen. And on the side there will be projecting transverse process. On the back there will be the spinous process. Got my point? Those sides are occupied by the transverse process, back is occupied by the spinous process, and the anterior part is the vertebral body. If you tuple it, there will be two upper articular process and lower articular process, and there is a distinct relation of these two articular processes. If you tuple it, the pedicle, the knot above the pedicle, the upper one is a shallow and the lower one is a deeper one. If you tuple it, hold it upside down, then the upper one, the knot in front of the pedicle will be deeper and the lower one will be shallower, which will denote that you have upturned the bone. Got my point? This is the dictum in identifying and side determination of bone. Gradually you will learn it once you go through the bone, right? Now how to hold it? In case of humerus, you have only maintained, you have not read humerus, alright? So I am not going in detail. You only need to know that the head will be medial, backwards and slightly upwards. Medially backwards and slightly upwards. No. Right? And if you can make it, humerus is held in normal anatomical position. Got my point? Now for the scapula, meaning clavicle, first for the clavicle, we know the anterior 2/3 is convex, posterior 1/3 is, and the later part, that is anterior 1/3 of the lateral part will be concave. Medial part is globular or quadrangular, lateral part is flattened, right? And there is a subclavian groove in the inferior surface. This much you know, right? Now you will, when you are given this bone, what will you say? What will you utter? It's a lateral bone. So above and below is known by, there is flattened upper surface and there is a groove in the inferior surface. Got my point? Anterior and posterior is known by, the medial 2/3 of the anterior surface will be convex forward. The medial 2/3 of the anterior surface will be convex forward. Alright, if you take this one, which one becomes lateral? This one becomes medial. This is not its position. So this globular part should remain in the medial direction and the flattened lateral third will remain in the lateral direction. Got my point? Upper surface smooth, lower surface there is a subclavian groove. Got my point? So anterior and posterior is known by, above and below is known by, and lateral and medial is known by. So it is a left-sided clavicle. Now how to hold? There is other criteria like the humerus. The head will be in a particular direction. Head will be in a particular direction to hold it in anatomical position, not the side determination. Side determination has been done. So you have to check the direction of the head, telling that it will be medially backward and slightly upward. Medially backwards and slightly upward. That holds it in anatomical position. Got my point? And for the clavicle, you have to say that this medial end will be a little lower than its lateral end. So you put this like this. Medial end is a little depressed than the lateral end. And it is also a little forward than the lateral end. Got my point? Medial end is a little lower than the lateral end. And the medial end is also a little forward than the lateral end. Got my point? So this makes its anatomical position. For male, what occurs in case of female? Both these levels are in equal level. That is, the medial end and lateral end is in the equal level, but the medial end is a little forward than the lateral end. Got my point? These are things written in the book, but you omit to give adequate stress, importance in this point. Got my point? Now, if you are given this scapula, all right. Now we know the scapula, there are two surfaces. This is the costal surface, this is the dorsal surface. All right. Three borders. This is the superior border, this is the axillary or lateral border, and this is the vertebral or medial border. Three angles. One angle is the glenoid or the superior angle. There is another angle and there is the inferior angle. This is lateral angle, this is the superior angle, and this is the inferior angle. And this is the spinous process, the self-like spinous process, and the lateral end is the acromial process. These simple things you know. Now, how to hold it? So, by this, you can determine the side. The above and below is known by the spinous process will remain above, right? Lateral and medial is known by the glenoid is on the lateral angle, right? And anterior and posterior is known by there will be the concave sternal surface with ridges for the subscapularis muscle attachment. So, it is done. But how to hold it in anatomical position? During examination, we hold it like this, like a revolver. Its nozzle facing towards, not just exactly towards the examiner, a little gently, a little lateral. Because if you misfire, the examiner will be gone. Right? Hold it like a revolver. And the tip of the coronoid process, don't point exactly towards the examiner, put gently a little away. This is the position of the anatomical position of the clavicle. So, one is the side determination and another is the anatomical position. Got my point? Rehearse this thing. Above and below is known by, lateral and medial is known by, anterior and posterior is known by. Then you will be able to determine the side. And there are some finer points to hold it in anatomical position. Done? Got it? Could you follow me what I have told? Yes, thank you. So, in the last class, then I will ask what is woven bone, what is lamellar bone, what is cancellous bone. All things I will ask in course of time. All right. Now, I have told the first week of, I have started first week of development up to the after fertilization there is formation of zygote, and the zygote enters into the phase of cleavage division by rapid successive mitotic division within the zona pellucida without much separation. You can remember? Then this accumulation of this blastomeres, the cells ensuing coming from the division of the zygote are called blastomeres. Then, and the plane of division alters and rotates, that I have mentioned. The zona pellucida covered the cell mass, that is the 16 cell stage morula, enters the uterine cavity from the fallopian tube on third day. Enters the uterine cavity on third day. By fifth day, there is formation of the, from the morula to the blastocyst. By fifth day, there is formation of blastocyst, right? In the morula, we have seen an inner cell mass and an outer cell mass. Inner cell mass is the embryoblast and the outer cell mass is the protective covering, that is the trophoblast. This trophoblast differentiate into cytotrophoblast, one layer of cytotrophoblast or different layer of cytotrophoblast, and there is another differentiation, that is the syncytiotrophoblast, which are aggressive and penetrates the endometrium, enters into the stratum spongiosum, eats it up and makes room for the vascular anastomosis and the formation of the placenta. Got my point? So, there is on third day the cells of cleavage division from the zygote enters into the uterus at the stage of 16 cells of morula. Blastocyst is formed by fifth day and the zona pellucida disappears by 5th day. Alright, all this comes as a MCQ question. Alright, and these are always asked in the Viva examination also. Alright, and from onwards 5th day, there will be process of implantation. Alright, as the syncytiotrophoblast enters into the endometrium, it penetrates. So, this uterine endometrium, so syncytiotrophoblast are entering. So, this is the pole that is entering within the layers of the uterus is the embryonic pole, and the pole that is hanging within the uterine cavity is the ab-embryonic pole. Got my point? One is the pole that is entering into the uterine wall, that is the embryonic pole, and the part that is hanging within the uterine cavity is the ab-embryonic pole. Got my point? With this, there is a reaction called the decidual reaction. There is a decidual reaction. The part of decidua, that is the part of the endometrium, that will cover this hanging portion of the blastocyst will be called decidua capsularis. That will be decidua capsularis, and that lining the uterine cavity will be decidua parietalis. Got it? And the part that lies in contact with the endometrium will be decidua basalis. So, decidua basalis, it is not like the stratum compactum, stratum spongiosum and stratum basale. Don't confuse this with decidua capsularis, decidua parietalis and decidua basalis. Got my point? Up to this, I have told you. Now, together with this, you need to know a little of the procedure of oogenesis and artificial reproductive technique, because nowadays artificial reproductive, you need to know something of the artificial reproductive technique. Now, let me start the process of oogenesis. Alright, there is a significant difference between the oogenesis and spermatogenesis. How? In case of spermatogenesis, the gamete start forming within the seminiferous tubules of the testes after birth, not before birth, after puberty. But in case of female, the primordial germ cells gets differentiated from the dorsal wall of yolk sac. Write this name. By 3rd week, primordial female germ cells develops from the dorsal wall of yolk sac. Dorsal wall of yolk sac. By this time, you don't know what is yolk sac. Alright. So, it differentiates from the endoderm of the dorsal wall of the yolk sac and is transported to the caudal end of the embryo via the dorsal mesentery, traversing the dorsal mesentery. Always again put a underline under the dorsal mesentery, because you do not know what is dorsal mesentery. So, these cells migrate to the caudal end of the embryo via the dorsal wall of the mesentery. Done. This is done by 5th week. So, 3rd week is the generation, 5th week is the migration. And from there they enter into the cortex of the developing ovary, where not the medulla. These primordial germ cells enters into the cortex of the ovary by 5th week. As soon as they reach the cortex of the ovary, they start multiplicating by mitosis and converts into oogonia. So, the first phase is So if you draw a flow chart, you start like this: primordial female germ cell by proliferation of endoderm of dorsal wall of yolk sac by third week, right? Then is the migration into the cortex of developing ovary. By the dorsal mesentery. What my point? Primordial germ cells appearing by the proliferation of the endoderm of the dorsal wall of yolk sac by third week, migration to the developing cortex through the via the dorsal mesentery close to the caudal end of the embryo by fifth week. Developing ovary via the migration into the cortex of the developing ovary via the dorsal mesentery close to the caudal end of the embryo by fifth week. All right. Then as soon as it enters the cortex of the ovary, it starts multiplication by mitosis and gives rise to the oogonia. Then it gives rise to the oogonia by third month. All right, by third month. At third month, some of the oogonia transforms into primary oocytes with an enlargement of the cell nucleus. This is the, at the end of the third month, there is formation of primary oocytes, right? By the conversion of the oogonia with enlarged nucleus, there will be the formation of the primary oocytes, right? By 7th month, all the oogonia will convert into primary oocytes. By 7th month, all the oocytes will be converted into, all the oogonia will be converted into primary oocytes, right? All right. Then, as soon as the oogonia are converted into primary oocytes, they enter into the prophase of fast meiotic division. They enter into the stage of prophase of fast meiotic division. At what time? At 7th month, right? It enters, the primary oocyte enters into the prophase of fast meiotic division, and it doesn't complete, and its rest, it doesn't complete the prophase of fast meiotic division and stays in a stage of Dictyotene stage, D-I-C-T-I, Dictyotene, T-Y-N-E, Dictyotene stage, right? For a long duration until until birth. So at birth we see that the total number of oogonia that were 2 million at during development, 2 million primordial germ cells. It will convert to 40,000 at birth. The cortex of ovary will contain 40,000 of primary oocytes at birth. 40,000 of primary oocytes at birth at the stage held at Dictyotene stage. That is, it doesn't complete the first meiotic division. Got my point? So where does this rest of the oogonia has gone? They have disappeared. Only 40,000 is remaining. And during each menstrual cycle, there will be selection of a cohort of primary oocytes of 6 to 12. There will be selection of 6 to 12 primary oocytes, a cohort, write the term cohort, C-O-H-O-R-T. C-O-H-O-R-T, a cohort of 6 to 12 primary oocytes will be selected to get maturation at puberty. From them, only one will reach full maturation. From them, only one, this primary follicle. What is the ovary with, what is the ovum with the flattened epithelial cells? I have drawn it earlier. From this cohort, maturation will start, and only one ovum reaches full maturation with the formation of a mature Graafian follicle. Let me draw. This is a maturing or secondary follicle, right? Where we can see the cell size has increased up to 35 micron, up to 35 micron. And in case of mature Graafian follicle, we will see the size of the ovum at 140 micron. These two denominations you have to remember. That is, at the level of secondary maturing follicle, we see the ovum at the size of 35 micron. All right. And at the stage of mature Graafian follicle, write down the spelling of Graafian. 99.99% students make a mistake in the spelling of Graafian follicle. Write down Graffian. Anybody else? All are wrong. Graffian. Graffian. All right. Correlate with your books. Correlate this. It is common. Graafian will become double F. All right. But it is Graafian follicle. All right. So at the level of it is secondary follicle, maturing secondary follicle. All right. Where the cell size has increased and the follicular cells has become cuboidal and multilayered. I didn't draw the multilayered. This becomes multilayered because the EA is disturbing. The blue sketch pen is disturbing. This will become multilayered like this. This will become multilayer. And there is a space in between the vitelloid membrane and the inner layer of the follicular cells. There is a space between this vitelloid membrane and the inner layer of the follicular cells. Remember, always, wherever there are some follicular cells, that is you can see in thyroid follicle also, there will be secretion of some fluid which creates a space. There will be secretion of some fluid which will create some space. This follicular fluid also will create a space in between the vitelloid membrane and the zona pellucida. Zona pellucida is what? It is the secretion of both the ovum and the follicular cells that will occur in this layer. I have drawn it earlier with striations. There will be some striations. This layer is the zona pellucida, which is a glycoprotein layer formed by the follicular cells as well as by the ovum or both. Why this striation is there? There are processes from the surface of the ovum, that is the vitelloid membrane, villi-like projection, as well as surface projection of these follicular cells that unite in this layer of glycoprotein, that is give rise to a striated appearance. Got my point? Within the glycoprotein, there are processes of the follicular cells as well as from the ovum that are anastomosing for the purpose of providing nutrition. Got my point? This is the maturing secondary follicle. Maturing secondary follicle. All right. Here, so by 7th month, we see this formation of this maturing secondary follicle, where this primary oocyte is in the stage of Dictyotene stage. That is, after the prophase, it is in the Dictyotene stage. Sometimes this breaking of this Dictyotene stage or the Handling stage remains up to 40 years or more for a woman. Remains for 40 years or more in a woman. And during puberty, what happens? This primary oocyte completes the fast meiotic division and give rise to secondary oocyte and the fast polar body. Should I erase this? Wipe off? As the follicular cells proliferate, there is accumulation of fluid in between the intercellular spaces of the follicular cells. And so there are compartments filled with antrum. The space is called the space is filled with the fluid antrum folliculi, and the space is follicular space. All right. When these coalesce with each other, there will be a cavity that separates from the zona pellucida. There is one inner layer of follicular cells and there is an outer layer of follicular cells. Both are connected at what point? Close to the ovary. Got my point? These are fluids accumulating into the layers of the follicular cells. This will coalesce and form a cavity. So these follicular cells will connect with one end of the ovary and at the other end of the ovary, which is strip of follicular cells around the ovary. The strip of follicular cells around the ovary is called the cumulus ovaricus, and that is away from the ovary is the stratum granulosum. The layer close to the ovary is the cumulus ovaricus or ovaricus. The layer towards the periphery of the ovary is the stratum granulosum. Now tell me a story, very interesting story. Whenever there is cloud, the mood of the female in our society always gets down. Why? Why? Cloud will provide some shadow, under which moving, going here and there will be easy. There will be no temperature, heat. But why the female get worried, anxious and depressed? Why this occurs with the women mood? What is the meaning of cumulus? In nephrology, you know the term. Stratus, altostratus, cumulus, cumulonimbus, nimbostratus, isn't it? So this is a cloud around the ovary that presses upon it and restricts its growth and maturity. So the ovary will not be released, ovum will not be released if it is placed under this huge cloud, the follicular cells forming the cumulus ovaricus. It will be pressed. What happens in a large family where there are many members, both male and female, many siblings, interrelated, there are a huge pressure on the girls, isn't it? So their maturity is somewhat halted because of this pressure of this much of the siblings. What my point? And the same thing happens due to this cloud, that is cumulus ovaricus. Got my point? All right. Then when this, by the time this mature this Graafian follicle, outside the follicular cells, what we see, there is differentiation of the ovarian stroma outside the follicular cells, what we see, there is differentiation of the ovarian stroma into a thecal sheath, which is known as, which is formed by a fibrovasculocellular layer, which is a fibrovasculocellular layer from the stroma of the ovary. It differentiates into two layers. Number one, the vasculocellular layer is called the Theca Interna. Vasculocellular layer is the Theca Interna. And the outer fibrous layer is the Theca Externa. Yes? Theca Interna and Theca Externa. This thecal sheath coming from the stroma of the ovary, alright, and it envelops the maturing Graafian follicle, and at the stage of mature Graafian follicle, there is, these cells already has entered into the second meiotic division, but has not completed it, alright. It will be completed after fertilization with the formation of, this is the first polar body, this is the first polar body. After the heterotypical division of, or reductional division of Meiosis I, the karyokinesis, that is the nuclear division, is equal, but the cytoplasmic division is unequal. So the most of the cytoplasm from the mother goes to one cell, which forms the secondary oocyte, alright, and the first polar body. Got my point? And after formation of the first polar body, this secondary oocyte enters into the second meiotic division, but doesn't complete it. It gets completed after fertilization. Got my point? And these follicular cells get reacted by the hyaluronidase of the sperm, and the ovum, the secondary oocyte, is released at the time of ovulation, 14 days prior to the next menstruation. 14 days prior to the next menstruation. Got my point? And this mature Graafian follicle ruptures, and the ovum, secondary oocyte, is released into the peritoneal cavity. How it looks like? It looks like this. There is the endometrium of uterus, uterine endometrium. The ruptured Graafian follicle, the Graafian follicle has the secondary oocyte of the size 140 micron. That was 35 micron in primary oocyte. In case of secondary oocyte, it is 140 micron. These two denominations you have to remember. All right. Then when it is released, not all the follicular cells come out. Not all the follicular cells come out. only a few follicular cells remains attached to the zona pellucida. All right, and this structure, this formation is known as corona radiata. Corona radiata. Got my point? Now remember one thing, that what the girl or the women, mature girl or the women is trying to be, what it wants to break, this rupture and the breaking of this cycle. What does the girlhood or the womanhood wants to do? It is trying to come out of the lunar cycle as well as the moonhood. There is a moonhood with long, curly, silky hairs, all right, rounded body figures. This is her possession, but he wants to break away from this cycle of moonhood. Got my point? And that's why when the secondary oocyte is released at ovulation, what is the term? Corona radiata. All right. So he wants what it wants? It wants a garland. That is a marital status. Got my point? A marital status. That's why he has worn this garland of corona radiata. And this corona radiata is dissolved by the hyaluronidase of the sperm when it is fertilizing. All right, and at that time of fertilization, the secondary oocyte will complete the second meiotic division, give rise to the ovum, all right, and the second polar body. Sometimes the first polar body also is able to divide and give rise to the first and second and the third polar body. Got my point? But this doesn't take part in fertilization. This doesn't take part in fertilization. So, after the rupture of this Graafian follicle, there will remain a remnant, a string Graafian follicle. There will be a string Graafian follicle with a central blood clot. After the extrusion of the ovary, there is a string constricted Graafian follicle with a central blood clot. This will convert into I don't have any yellow marker, all right. So this space, assume that this space is filled with some keratinized yellow substances, all right, and these are the radiating vessels. This is called corpus luteum. This is called corpus luteum of, ठीक है? If pregnancy occurs, it will become corpus luteum of pregnancy. Otherwise, it will degenerate and will become corpus albicans, a white irregular body with fibrous tissue inside. This is corpus albicans. a whitish irregular body within the cortex of the ovary. This is called corpus albicans. You have to know in detail about the corpus luteum, because what are the hormones it produces, how it helps in the initial months of pregnancy. It produces both estrogen and progesterone to maintain the pregnancy. All right. So this is called, then it will be called corpus luteum of pregnancy. It remains for around 90 days, 3 months. All right. To supply the steroidal hormone to the developing fetus. And when the pregnancy doesn't occur, it transforms into a whitish fibrous body known as the corpus albicans. Got it? Got it? Now, as you know, the menstrual cycle is counted from the first day of current menstrual period to the first day of the next menstrual period. It is roughly 28 days. That is in lunar month. There may be 3 to 4 days advancement or recession. All right. But ideally, the ovulation takes place 14 days prior to the first day of next menstrual period. And women can remember it due to their rise of body temperature and some other features. Right. They can remember the day of ovulation. My ovulation date is coming. I should remain prepared. All right. So this is oogenesis. Done? Everyone? You can make the flow chart and draw the diagrams accordingly by your side. Only a little diagram, not much is needed. All right. Just mention the stages and the important features of that stage. Not more, because you don't have that much of time. Right. Now let us talk about something about the in vitro fertilization or artificial reproductive techniques. All right, ART. There are few methods. One is in vitro fertilization or ZIFT, Z-I-F-T, ZIFT. ZIFT is also an in vitro fertilization where the fertilization is done outside the body, and then the zygote is implanted within the fallopian tube. So ZIFT means zygote implantation into the fallopian tube. And there is another technique called GIFT, G-I-F-T. There is gametes. There is transfer of both gametes in the fallopian tube. There will occur the fertilization and this will be implanted into the uterine cavity. This is called GIFT. What we want to know, that is pre-counseled genetic standard of the male and female couple, male and female. We do a pre-genetic testing by which what it yields any genetic abnormality already present in the couple. All right. And more important is we can select the gender of the offspring. And this is why the artificial ART, artificial reproductive technique, is banned, totally banned in some countries. And some countries give only very rare permission of aged couple without any children. Got my point? Because sex selection, you see, in 1978, the doctor named Karsov in Cottage Hospital of Royton, Oldham, England, he first gave a woman an IVF child known as Louise Brown. Write down, L-O-U-I-S-E, Louise Brown, B-R-O-W-N, born out of a natural cycle, natural ovarian cycle. That is, he was not given any ovarian stimulation drug that is given today. That is the clomiphene citrate. Clomiphene citrate is in the ovulation inducing agent, but she was not given any ovulation induction agent. The ovum was taken and it was subjected to intracytoplasmic injection of sperm outside the body. intracytoplasmic injection of sperm. That is the most popular technique of in vitro fertilization. And when the zygote has formed, that is again reimplanted within that mother, not in a surrogate mother's uterus. Got my point? Not in surrogacy. And the child matured, the mother gave birth to a fully matured child, and he lived without any genetic abnormalities, and mother didn't suffer from any hyperovulation syndrome that occurs with the stimulation of ovary through the ovulation inducing drugs like clomiphene citrate. When you put expectant mother under ovulation inducing drug, that is a clomiphene citrate, there could be three problems. Number one, hyperovulation syndrome. Number two, abnormal twins, triplets, etc., that is multiple birth, and there is abnormal genetic conditions. You have to avoid these three things. All right, and the doctors and the team will be responsible for all these mishaps. Got my point? That's why, and there is a chance of gender selection which is banned in many countries. That's why this is banned in many countries. There are much more ethical issues. Vicky donor dekhecho tomra? Have you seen Vicky donor? Have you seen Vicky donor? What Anu Kapoor was telling to Vicky donor? You are a hierarchical family member of Alexander. You have very good sperm. Your sperm could fertilize ovum of any women. So it means that the sperm doesn't belong to the husband. It may be from any other person. And that is the fallacy and ethical issue in case of in vitro fertilization. This team member of this first in vitro fertilization, there was a doctor known as Edwards. IVF technique was developed by a team, and one member was Robert Edwards, and he was awarded a Nobel Prize in 2010. He was awarded a Nobel Prize in 2010. Let us finish today. All right, let me finish. Thank you for patient listening.